谢谢几位主席。首先对不起，我的普通话讲得不好啊。如果用普通话讲的话，我相信4、5分钟我肯定讲不完。讲完了大家也听不懂。So excuse me, I will conduct my presentation in English. So I'm going to talk about mHSPC new developments. So in previous speaker, we see that actually we have ADT as a standard treatment for almost 100 years, and then there's not much progress in the past during the first 100 years, but then in the past around 15 years, we have a lot of new drugs coming up that will actually change our treatment strategy and also change the whole concept of treating mHSPC. But are all mHSPC the same and we treat the same? But you know about the synchronized and metachronized mHSPC will actually present differently. The tumor burden will be differently, and also the tumor biology may be different. So we shouldn't take them as the same thing. And then we look about high volume, low volume, high risk, and low risk. Again, the definition is a bit arbitrary, but then for more aggressive tumors, more high-load tumors, probably the treatment will be different from those with a lower risk. And with the PSMA, PSCD, we are taking a lot of oligometastasis at presentation. Again, we probably will not treat them as the same as the high volume, high risk multiple metastasis disease. So, we actually cannot just look at mHSPC as a single item. There are different patient spectrum. Today, I will actually concentrate on talking about the more high volume, high risk disease. So this is Hong Kong status. So you can say that at presentation, around 30% is actually stage 4. That means that they present with metastatic disease, which is not a very good scenario because if the patient present early, then the treatment, we can give curative treatment and the response and the result will be very good. I have looked up, I think in China, the presentation with stage 4 disease also around 20-something to 30%, which is, again, not very satisfactory. So you can see that with treatment, we use localized disease and then recurrent disease, and then castration sensitive, and again to castration resistance. The tumor volume and tumor load is actually getting worse and worse. So we try to minimize the treatment load and the difficulties we treat the patient by treating the disease early. So right now in 2023, I think we can confirm that doublets are better than ADT alone. So we shouldn't use ADT alone in mHSPC apart from some very specific, very early cases. So I won't go into detail because you all know that ADT plus chemotherapy is around for more than 10 years. The Chartered and Stampede established the role of docetaxel in the first-line mHSPC setting. And for ARPI, again, I won't go into detail because this is old studies, and you all know that we have abiraterone, enzalutamide, apalutamide, and recently darolutamide all showed survival benefit when we added it into ADT in the first-line setting in mHSPC. So these studies show us that ADT plus ARPI or ADT plus chemo is actually the standard of care now. So for these studies, the conclusion is that ADT alone is not adequate for almost all patients. So either ADT for docetaxel or ADT for ARPI is a standard of care for mHSPC. But is triplets, so we move forward. So is triplets better than doublets? Again, this is a study that sort of comparing triplet with doublets. This PEACE-1 study is actually adding abiraterone to what we call the standard of care. And the standard of care initially when the study started, it was just ADT, but then it moved to ADT plus chemotherapy. So effectively, it's actually testing adding abiraterone to ADT plus chemotherapy. So it's not exactly a 3 drugs versus 2 drugs comparison. So it's actually adding ARPI to the combination of ADT plus chemo. Again, the study showed that the data is that they're quite balanced on both arms. And we look at the OS in the overall population, we can see that actually there's a positive study, there's a separation of the survival curve with the, medium survival is much better with addition of the abiraterone with a hazard ratio of 0.82. And if you look at the OS with abiraterone in the ADT per doxorubicin population, you can see that it's actually much better than those patients without abiraterone, with or without radiotherapy. And subgroup analysis, we can see that they all favor the additional of abiraterone. And we look at the OS result comparing with other studies, we can see that the PIS1, the OS is, the mean survival is 61 months compared with the previously study. You can see that is definitely some improvement in that. And of course, with more drugs, there's more toxicity, as Professor Shea have mentioned. So we have to be very careful to look at it. Adding abiraterone to ADT plus chemo did not add too much of toxicity because we all know that abiraterone is by itself is a more tolerable drugs. So most of the toxicity is actually come from the chemo arm. So additional abiraterone, although we will give a bit more toxicity, the patient tolerance is not that bad. So the PIS1 conclusion is additional abiraterone to ADT and docetaxel significantly improved radiographic progression-free survival in de novo metastatic castration-sensitive patient without adding significant short-term toxicity. And also improve the 25% reduction in the risk of death, even when 81% of the patients in the control group subsequently receive at least one next-generation androgen sulfate. So moving it forward is better than sequentially. So that is the conclusion. And Aracin is a newer study, is directly comparing darolutamide plus ADT plus chemo versus ADT plus chemo. Again, it's a large randomized study, and the primary endpoint is overall survival. This is a baseline, and just to show us that actually the patient on both sides are quite balanced. And the most importantly, we look at the result, the OS survival, we can see that darolutamide significantly improved the overall survival compared to the ADT plus chemo arm. So with the median survival of with a much better, with a hazard ratio of 0.68. And when they presented the study, the median survival of the triplet is not yet reached. And for the placebo arm, that is doublet, is around 50 months. And if you look at different subgroups like high volume, low volume, high risk, low risk, you can see that actually the separation is still there. So it not only benefit the high risk patient, the more aggressive tumor, it also benefit the patient with lower risk and better prognostic patients. Again, you look at all the secondary endpoint, there's also improved in all the secondary in all the secondary endpoints. And AE, again, of course, there's additional AE, but then again, the toxicity is not that much comparing with the already present toxicity from the chemotherapy. And so it actually is quite tolerable and is quite not too, I would say it's not too difficult to manage. So for Aracin's conclusion, in this trial involving patients with metastatic hormone-sensitive prostate cancer, overall survival was significantly longer with the combination of darolutamide, androgen deprivation therapy, and docetaxel than with placebo plus androgen deprivation therapy and docetaxel. And the additional darolutamide led to improvement in key secondary endpoint result also. The frequency of adverse events was similar in the two groups. So with these results, are we going to give triplet to everybody? Is it become a standard? I think for high volume, high risk disease, triplet therapy is a preferred approach. But for low volume, low risk disease, triplet benefit is less clear. We have to look at individual patients' characteristic and also discuss with the patient. we have to consider patients' comorbidity, performance status, and also the patient preference. Especially in patients in Hong Kong, most of the time the patient have to pay for the drugs, so it's very expensive for the treatment for them. So, and again, we have to again remind that this triplet therapy versus doublet therapy is actually additional of ARPI to chemotherapy ADT. So we don't know the benefit if we add chemotherapy to a doublet with ARPI. So moving forward, I would spend the next 5 minutes talking about the new approaches. So this is a study that was just presented in ASCO a few weeks ago. So it's moving PRAC inhibitor, in this case, to the mHSPC place. So they are using niraparib in the setting. So this is the presentation at ASCO this year. So the baseline characteristic between the two groups, the NARA group and the placebo group, is comparable. And that is the result. So we look at the results. Is the primary endpoint is the radiographical PFS. You can see that for the BRCA arm, if you look at the subset of BRCA arm, again, you can see that additional of the ARPI to the combination of ADT and ARPI significantly improve the PFS. Even the patient, if HR they look at it as a whole group, there's still benefit, although the benefit is not that obvious. It still shows a definite benefit over the doublet arm. And then you can look at all the subset analysis. It's almost favor the triplet arm than the doublet arm, except for those M0 patients and those patients with and also the Asian population. But then you have to remember that the number of these subgroups are very small, so we cannot draw conclusion from a small number. So basically, it seems to benefit all subgroups. And then if you look at time to symptomatic progression, again, if you look at the whole group, the HRR group, we can see the benefit. But if you look at the BRCA arm, you can see that the benefit is even greater. So you look at the OS, it's a bit early to look at the OS, but you can see that there might be already some separation in the BRCA positive arm. So we will look forward to the, so from this, we can say that actually there's also improved overall survival in the BRCA positive patients, but we are looking forward to more mature results, probably in 1 to 2 years. So the result, again, you can look at subgroup analysis by BRCA and not BRCA and non-BRCA alternative. You can see that it's actually favored with BRCA. If you have the BRCA mutation, the benefit is more pronounced. So we have to actually look at the HRL group as not a single group, look at different subsets, because if you choose every patient in HR progression with more drugs, probably will bring more toxicity without much benefit. Again, you look at subsequent therapy, you can see that both arms also have subsequent therapy. Of course, it's different because we use the PRAC inhibitor in the first-line setting. When the patient develops mCRPC, probably we have to choose other drugs. Safety, again, is actually similar with the additional toxicity with the PRAC inhibitor. So I won't go to details there. So conclusion is that it makes a primary endpoint. It's the first trial to show that efficacy of combination of PRAC inhibitor and ARPI in the mHSPC setting with patient with HR alteration and improve a PFS are supported by statistical significant benefit in time to symptomatic progression. And the safety profile is actually quite acceptable. So apart from the niraparib, actually we have other PRAC inhibitor going through this study. Teraprofri is just actually completed recruitment, and I think it used talazoparib, but in the same similar setting. The recruitment is completed. I think we will have the result in probably, again, 1 or 2 years. Moving to lutetium, this is an upfront PSMA, a small study. We show that lutetium can be added to the mHSPC scenario with minimal side effect and toxicity. And so this is an upfront PSMA. It's an ongoing study moving lutetium PSMA upfront, comparing this with ADT plus docetaxel. So we additional docetaxel we add lutetium, and we'll look at the final results later. Again, this is a PSMA addition. Again, is moving lutetium at the mHSPC part. So again, it's moving all the MCRPC drug to mHSPC and see the results. Ongoing study, they're looking CDK4/6 inhibitor. This is cyclone-free. Again, is adding the new drug to abiraterone and ADT in the first-line setting. This is the Capitello 2H3 AKT inhibitors, again in the first setting. This study had not been presented, but there's a press release saying that in the capivasertib in combination with abiraterone and androgen deprivation therapy demonstrated statistically significant and clinically meaningful improvement in the primary endpoint of radiographic PFS versus abiraterone ADT with placebo in patients with PTEN deficiency, de novo metastatic hormone-sensitive prostate cancer. The OS data was in mature time, so we are waiting for the final official presentation of this study. So just quickly, NGS and prostate cancer. Right now, we are popularly advocating that use it in MCRPC setting, but with all these new drugs, probably we're moving it forward in the mHSPC setting. For example, nowadays we just recommend a high-risk de novo mHSPC. Otherwise, we reserve it in patients with MCRPC. But with all these new drugs coming up, probably we are going to move it forward at diagnosis, especially for those patients with high volume disease. So in summary, doublet is the second standard of care now, but ADT plus ARP plus chemotherapy should be considered high risk, high volume disease. And more treatment options with variable biomarker is important. NGS should be considered in high risk, high volume patients. So we're looking forward in maybe a few years later, probably we can see that we are using different markers, different things to tailor-make a patient in the mHSPC situation and probably improve the survival of this patient. Thank you.